и буду записывать. Мы сейчас начинаем наш журнальный клуб, и я буду записывать его. Если вы вдруг не хотите, чтобы ваше лицо попало в эту видеозапись, то держите свою видеокамеру, так сказать, turn off, да, микрофон, соответственно, тоже лучше быть выключенным, чтобы какие-то шумы на заднем фоне нам не мешали. Что я сегодня хочу сделать немножко по-другому. Давайте немножко разогреемся и познакомимся. Так как у нас обычный интерактив очень такой слабенький, я хочу все-таки вас немножко сегодня стимулировать для вопросов. Начнем по-русски. Давайте каждый, вот я называю имя, вы включаете микрофон, по возможности включаете видеокамеру и представляетесь. Давайте я начну с себя, потом называю имя и делаете представление. Мини. Меня зовут Марина Ветрова, я врач-психиатр-нарколог, я научный сотрудник университета Павлова и модератор журнального клуба сегодня. Марина, дальше.
Здравствуйте, я студентка 5-го курса лечебного факультета 1-го меда. Вот, сегодня я презентую вам статью, и также я могу ответить вам на некоторые вопросы по журнальному клубу, если они у вас появятся. Вот.
Следующая Ольга.
Здравствуйте, меня зовут Ольга, я студентка 3-го курса лечебного факультета ПСПбГМУ имени Павлова. Также участвовала в журнальном клубе как докладчик и всегда участвую как слушатель.
Прекрасно. Так, Екатерина.
Всем добрый день. Я Екатерина, я студентка 4-го курса лечебного факультета, также ПСПбГМУ имени Павлова. Ну, я также представляла статью на журнальном клубе в марте. Вот, и также стараюсь быть активным слушателем на всех журнальных клубах, которые проходят. Ну, может, не всегда активно, но всегда стараюсь слушать и кое-что запоминать. Спасибо.
Прекрасно. Иван.
Здравствуйте, меня зовут Иван Сорокин. Я блогер и немножко политик, член регионального совета партии «Яблоко». Тема, которой я занимаюсь, это гуманизация наркополитики в Российской Федерации. И вот я пришел просвещаться, немножко послушать.
Прекрасно, рада видеть.
Взаимно.
Так, и Наталья.
Да, здравствуйте, меня слышно?
Да.
Да, я Наталья, научный сотрудник института Бехтерева, научно-исследовательский центр психиатрии и неврологии. Являюсь активным слушателем журнального клуба. Вот, и, в общем, с удовольствием тоже в этот раз активным слушателем. Вот.
Супер. Спасибо большое всем. Okay, so let's turn to English, because our journal club is unique, because we are speaking in English, because we would like to practice to talk about science and to discuss about scientific problems in English, because this language is primary language for science. So couple notes. First of all, as I say, we video recording whole meeting. Also, we would like to make this presentation as more interactive as possible. So please, if you have any questions, please ask me or Marina, any Marina, which you like, you can ask questions. Also, we would have, we also plan a Q&A session after presentation. So if you don't want to interrupt us, Marina, so just write your question and ask it after presentation. And every time, I think you already introduced yourself, so there is no need to introduce yourself before asking questions, but usually it's very good practice before asking questions, present yourself. And also, as I said before, keep your mic off and video on, because it's create more human-like atmosphere. And after this after this journal club, we send you short survey. It's very short, and we would like to collect some feedback from you, because it's super important to know what we do right or wrong and how to make us perfect. So please just take few minutes to complete the survey. It's super important for us. Okay, so let's get started. And next slide, please. Here, emails of presenter and mine. If you don't have it, so please make a screenshot. And if you have questions after Journal Club, also please feel free to send them to us. And so let's get started. Today we talk about very interesting topic which related to neuroendocrine system and why it's important in patients with substance use disorder, particularly in alcohol use disorder. And this article is kind of interesting because it was the study was conducted in Tomsk by Russian scientists, and I hope you enjoy the show and this presentation, and would have a lot of questions. So Marina, your turn.
Yes. The article was posted in the American Journal of Addiction Research and Therapy in 2016. Impact factor as of 2016 year was 0.37. The main problems in the articles that the problems of alcohol addiction and its treatment. And second problems is potential mechanism, neuroendocrine system. In this article, an interesting approach to alcohol addiction treatment is considered. It deals with the connection between two systems, endocrine and nervous system. What is the connection between the endocrine system and addictive disorders? Which hormones are involved and why? Why does this approach take place in the treatment of alcohol addictions? So let's deal with it. Hypercortisolemia was found in alcohol withdrawal syndrome, as well as in patients with the phenomena of alcoholic delirium against the background of withdrawal syndrome. In some studies, it was found that with increasing cortisol concentration, hippocampal neurons atrophy occurs with the neurotoxic effect of glucocorticosteroids. On alcohol withdrawal, hypersecretion corticotropin releasing factor was found to activate the enterohypothalamic pituitary system. Dihydroepiandrosterone levels were also decreasing, likely a result of chronic exposure to alcohol and abstinent status in this patient. Dihydroepiandrosterone has greater sensitivity to increased levels to adrenocorticotropin hormone compared with cortisol. The DHEA neurosteroid has a neuroprotective effect and protecting brain neurons from glucocorticosteroid-induced neurotoxicity. So DHEA can be considered as a cortisol antagonist, and the ratio of cortisol to DHEA as an important marker of the hypothalamo-pituitary adrenal activity and anabolic balance and allostasis. Why the levels of cortisol and adrenocorticotropin hormone elevated in patients with alcoholism compared with of healthy people? Elevated cortisol is typical for the state of distress and depressive disorders, peculiar to alcohol withdrawal syndrome associated with deficiency of gamma-aminobutyric acid. In affective disorders and alcoholism is a violation of a negative feedback mechanism by which released from the adrenal. Cortisol inhibits the production of the corticotropin releasing factor, causing the contents of the corticotropin releasing factor, AKTG, and cortisone increases abnormally. Why is GA and gas sulfate level reduced in people suffering from alcoholism? It should be said that dihydroepiandrosterone and dihydroepiandrosterone sulfate are hormones that have a powerful neuroprotective and antiglucocorticoid effect on the brain and can protect neurons from the neurotoxicity caused by glucocorticosteroid. DHEA is more lipophilic and stable, so it is not DHEA sulfate that is used for measurement and evaluation. Likely a result of chronic exposure to alcohol and abstinence status in this patient. DGA has greatest sensitive to increased levels of AKTG. Study objective is to investigate the effect of 21st day course of Galodif on blood steroids level among patients with alcohol withdrawal syndrome. The drug under investigation is an anticonvulsant drug registered only in the Russian Federation under the trade name Galodif. To be honest, I found only one site with information about the drug and the fact that it has passed only the development stage, but has not yet reached the clinical trials in humans on the indication of anticonvulsants. There were only 4 experimental articles in PubMed where the doses used were between 100 and 250 milligrams per kilogram in gastric on animals. The study used off-label. Summary questions about the choice of this particular drug, this dose, and whether or not the dose correction was made during the study remain open. Study design in experimental comparative study of Galodif effect on neuroactive steroid hormones among patients with alcohol addiction with control group. In a study was 2 groups, patient group and control group. Inclusion criteria was diagnosis, mental and behavioral disorders due to use of alcohol dependency syndrome, and mental and behavioral disorders due to use of alcohol withdrawal state according to ICD-10, and male sex.
Question. Why they chose only males?
I don't know. It's not written in the study.
What do you think?
I don't know.
Is anyone have any ideas why they include only male in the study when they trying to answer a question of how the treatment can change hormone level in people?
May I say a few words?
Ekaterina?
I suppose, yes. I suppose that on female it is cyclic hormone cycle of hormones, and this state can interrupt in results about DHEA and cortisol levels, and on male there is no such problems. I think so.
Yeah, I also agree with you. I think that the problem that like gender is additional factor which should be controlled because it can modify our results, and just simply remove this factor and focus only on the sample population of male, we just decrease the chance that results will be modified by gender, and only we can see like more clear effect of treatment on hormone level in this population, because we just remove one factor which can be very important for our results.
Okay.
Yeah, and also here I would like to notice that this is exactly what Marina take from the articles. I hope you all read it before this Journal Club. And I find it kind of interesting how they explain the inclusion criteria, and they talk about diagnosis, that is alcohol, it's alcohol dependent syndrome and alcohol withdrawal. And it looks like they include people during detoxification because it was like this treatment was done in clinical settings. So, and probably these people receive some therapy for withdrawal syndrome, but in this paper they don't really point it out, and we don't really know, do these people was on withdrawal when they included in this study, and it was like first day of withdrawal or second day. So I just want to like point out that here we put all inclusion and exclusion criteria which was in paper, no more other information.
Yes. From the article, I understood that criteria exclusion was patients with our comorbid psychiatric and endocrine disorders reporting about using of medications that could alter the levels of steroid hormones, serious liver disease. In fact, I don't see that exact criteria described the ethical or the methodology used to evaluate the following conditions. For example, did not have serious liver disease, but which laboratory and instrumental studies was this confirmed? Also, it was not indicated. And what Marina says is what day from the beginning of detoxification therapy where the participants include the study, did the patients have over addictions, HIV status, cognitive impairment, is not written how the degree of alcohol withdrawal was assessed. And so it's hard to tell if the sample was representative. So the interaction was the same for both groups, is anticonvulsant Galodif in doses of 300 microgram a day, during 21st day. Outcome in the study was reduction of adrenocortical-dropping hormone, cortisol, DHA, and DHA sulfate, and ratio cortisol-DHA in blood. Measurement was blood samples were collected every day in the morning on the empty stomach, and enzyme-linked immunosorbent assay. Also does not indicate which day the detox therapy was tested, and it's not clear that the tests were taken every day, and the assessment of the tests was only the first and 21st day of therapy. Have been any change in dynamics? In a study was two groups. In first group was patients. Number participant is 68, and second control group number participant is 23. Mean age was 30 plus minus 10 years. So it may be noted that in the process of the study, 5 participants dropped out of the first group and 4 participants on the second group. The reason was not explained. The data can be seen in this table. This table that show levels of hormones in the blood serum of alcoholic patients and healthy volunteers before and after treatment. What is explain asterixis mean? For alcoholic patient in the first column, asterixis mean there is a significant difference between the two groups, volunteers and alcoholic patients, before treatment. The second column is in the same group. Asterixis refer to a significant difference before and after treatment. So, as was said in the beginning, the study of cortisol and adrenocortical levels showed elevated levels in patients with alcoholism. This compared with the control group of healthy volunteer. And a significant reduction in the level of DHA and DHA sulfate in blood serum for patients with alcoholism. We see an increase in the parameters of people with alcohol abuse relatively healthy volunteers, but the article did not say that the parameter of people with alcohol abuse don't exceed the norm of people. Norm of DHA for men age 30-50 years at 1.50 at 11th 17, and cortical's norm is 150 to 660. In this picture is presentation boxes. This first picture demonstrated statistical analysis of the level of ketogen blood serum of patients with alcohol and volunteer, and a second picture demonstrations of level of cortisol. The first box is volunteers before treatment. The second box is patients with alcohol addiction before treatment. And third and fourth box is volunteers and patient with alcohol after treatment. Sorry.
Can you just comment what do you see here on the first graph when you see ACTH level? So what we can see here, that there are difference between patient and control group on first day and after 21 day.
I think what a significant difference was in patient with alcoholism between second and first groups box, but no significant difference in volunteers.
So we see, first of all, we see difference between volunteer and patient group, right? Control and patient group on first day, and also we see difference in patient group during the time, right?
Yes.
And the same results was for cortisol, right?
Yes.
So it was a difference on the first day, and we see that patient returned to kind of like normal level of hormones after 21 days.
Yes.
Can you return to the first table, please? When we look on these levels, like numeric data, and when we look on ACTH level, and we see that, okay, we don't see difference between volunteer, like over time, like for volunteer group, nothing changed.
Yes.
And we see significant difference on the first day between patient and control group. But looks like after treatment, there are no difference between control and alcoholic patients. I just, it's interesting because, oh no, it's mean like that we don't see asterisks on the second, on the after treatment for alcoholic patient. It means that there is no difference between prior and after treatment for patients,
Yes.
right?
Yes.
Okay, so statistical significance, they don't, like, it's not significant results for
Yes.
ACTH.
For
Okay. But can you return again to this graphs? Okay. Okay. So I don't know, like, what do you think? For me, it's kind of strange because, like, for cortisol, if you look on only on patient on first day and on 21st day, it's kind of very similar pattern of change for figure 1 and figure 2. I mean, this is like clear. It's supposed to be significant. Like, it's supposed to be significant.
Maybe,
statistically, because these box plots are very, very different, and they're not how to say covered between each other. And I mean, like here, like on graphs, I see this is like pretty same results.
Yes.
Okay.
Maybe.
Okay. Okay. It just, for me, it looks very strange. And unfortunately, we don't know, right? We don't know like which statistical test they used.
Yes, we don't know.
And how they find this. Like, because when you look on graph, like first of all, when you actually assess the data, you look on graphs, because it's like it give you more clear information, like what is it difference, and on which direction you see this difference, is like lower or higher level. So, and I actually prefer to see like graphs, and I really appreciate that authors give us this information. But for me, it looks like not really similar. Like for me, it's strange that like I think tables with numeric data is kind of contradict with what I see on graphs.
Yes.
What other things? Maybe anyone else have other comments about? So this is like primary results. This is what they trying to find. Like, is a difference between like during the period of the observation, is a difference between day first and day 21, and there's a difference between patient and control group. And looks like they find, based on these graphs, they find they support their hypothesis that there is difference. Okay. Okay, let's move to next results.
In this picture demonstration, the statistical analysis of the levels of DHA and DHA sulfate in blood serum. So in patients with alcoholism and volunteers before and after treatments. So the results show that the initially allowed levels of DHA significantly increased, that indicated the stimulation of synthesis of DHA. It can also be seen that DHA's level was low before treatment, maybe because the DHA level was also low. But even after treatment, DHAS was even lower. A decrease in the pool of DHAS sulfate in connection with its transition into the more active non-sulfate form DHA, having greater lipophility and the permeability of the blood-brain barrier. But it should also be remembered that the indication do not go beyond that norm. This table in which we see the ratio cortisol and DHA and DHA sulfate in alcoholic patient with and healthy volunteers before and after treatment. So we can see that the ratio of cortisol DHA in alcoholic patients twice the index of healthy volunteers in the control group. Why is the cortisol DHA ratio reduced? Reducing elevated levels of cortisol and the ratio of cortisol DHA also associated with an increase in DHA levels in patients with alcoholism on the background of the therapy. So it's a positive response to treatment with an anticonvulsant Galodif. Summary result of the study was a course of Galodif starting during alcohol withdrawal syndrome lead to normalization of steroid hormones balance. And the article did not declare or conflict of interest. However, it expressed gratitude to Mr. Vladimir Khudaley, who is the General Director of Science, Technology, Medicine, but also he General Director to Senegal company, Science 2010. Senegal has been producing Galodif. So it's possible to declare a conflict of interest in here.
Yeah, I think it's important that you point out this detail, and I think it can be a lesson for us when we. It's okay to be in partnership with other medical and technological organizations, but I think it's like usually like as a scientist, like ethically you should to disclosure all of your conflict of interest, and I think it's very important to say what exactly, how exactly the person who totally interested in the sale of this medication, how he, what is his role in the conducting of the study? Is he participate in design or in interpretation of these results? Or is he do statistical analysis? Like we really need to know this information. It's okay like to do this and to involve the people from industry in academia. It's probably nothing wrong with it, but you should be very clear about this and to make your readers to make more appropriate conclusions about your results. So I think they doing great, but they a little bit I would like change. I would like to see change the section of conflict of interest because I think there are some conflicts here. And back to results, can you repeat? Can you go back to the previous slide? Okay, and one more on this table. Okay, so like your explanation that we see this reduction of cortisol because we see increase in DHEA levels because probably, so just to think about this, we include patients during alcohol withdrawal syndrome, right? And
Yes.
then 21 days, it's like 3 weeks, we follow up them. And I think it's also not really pointed out in this article. We don't really know, do they relapsed or not? So do they return to alcohol or they in remission?
Yes.
So they not using any alcohol and they kind of on the stage of early abstinence. So they're in remission. And I think it's very crucial to know about this because if they relapse, you probably will see like more cortisol or less cortisol. We don't really know. And the other point that after 3 weeks, so we analyze cortisol level during withdrawal, and we know that withdrawal is kind of stressful event, right?
Yes.
So and probably what we see on withdrawal just normalized after time. So and only like it's actually time cure these abnormal levels of cortisol. And here I think it's very hard to distinguish where is effect of time or effect of Galodif.
Mm-hmm.
What other think about this? How like so this is our primary results. Do you think the next slide when we actually just repeat what's saying in paper that Galodif can be used for normalization, steroids, how likely you agree with this conclusion?
May I say?
Mm-hmm. Yep, Ekaterina?
I agree with you, Marina. I think that it is time result because they are not doing any statistics about time covariate, and they do not measure it. So and they do not wrote it war patients in withdrawal on the baseline. And I suppose that it is not an effect of drug itself, and they should do some statistic measures about time and write it in their article.
I think I would like to make other suggestion for changing the design of this study, and just to add control group of patient, and just randomly one group of patients receive Galodif, the other don't receive it, and to see is it time effect or is it effect of Galodif. And so for me, it's I understand why they choose the control group of healthy volunteer. So to see like how is it only so probably the question was like, is Galodif can change our HPA axis when it's dysfunction? And in normal, like in healthy volunteers, HPA axis functioning is normal. So, and when we add Galodif in normal state, there are no change. And I think it's also important to know. But in particular, in this study, I think just adding one more comparison group, person, like group of patients who don't receive Galodif, will be very crucial. Yeah, and also like to make it as all clinical trials, like make it randomized and controlled. So and probably it will be like four group with placebo group as well. But for like both for group of patients and for group of controls. And yeah, is anyone have any other ideas?
I have one question.
I even don't understand what is Galodif. It is anti-coagulant, and what is the target of Galodif? What receptor which is effects?
Yeah, I think it's a great question. Like,
yes, that's a good question.
Isn't the paper they discussed about this potential mechanism of action?
No, it's in article not said what is Galodif and what's mechanism. So I don't find this information. So I don't know its an answer.
Yeah, I think this is one of the questions, like with this paper, that how actually they come with this idea. And usually you find this information in introduction, when scientists just like make some references to previous papers, when you can understand how these study questions come to mind of this scientist. But unfortunately, it's really not clear. So they talk about epileptogenic concept of understanding of addiction, and just see when you see addiction as epilepsy, it's kind of like concept of understanding what is addiction is. And when person have a craving, it looks like an aura during epilepsy, and person just couldn't control it, and it's kind of like seizure in epilepsy, but in addiction it's relapse. And it's related to I think this concept is mostly it's not really like physiological concept. It's a concept of
Yes.
it's conceptualization of this problem, and because we don't have like effective methods of treating addiction right now, and we are trying different strategies, and anticonvulsant work in epilepsy. So let's try it, like because we have this epilepsy-related concept of understanding of addiction. But I think this is really the problem, that we don't really know mechanism. But and also it's okay that I mean, like this is study. It's kind of fishing expedition. Like you don't really know what you find, and it's not really like clinical study when you're trying to find the to show the efficacy of this treatment. You just trying to find the effect of the treatment who successfully probably used in epilepsy, and to see how it can change hormones and steroids level. And for me, it's also like a lot of unclear logics in this, and I don't really know. And I actually invite author of this paper, but she's not respond me. So unfortunately, we couldn't ask these questions. But I think this is nothing wrong that we don't really like. It's kind of like new treatment, and we don't really know about the mechanism. So probably this study can help us, and actually we would like gain knowledge about this mechanism by this study. And it's kind of like pilot study. There are like less than 100 person participate in this study. So it's okay, but I don't know. This is a great question, but I don't think that we right now have the answer. Hope it's help. I know it's not, but yeah. Natalia, Natalia is neurologist from Bekhterev University Institute, excuse me, and National Center. And Natalia focus on epilepsy, and probably, I don't know, like, do you familiar with the concept of using anticonvulsant in treating addiction? And what do you think about this?
Извините, я буду на русском.
Хорошо.
Ну, вообще, что касается этого препарата...
Ой, а можно погромче? Плохо очень слышно.
Небольшая проблема с наушниками. Что вообще касается, в принципе, этого препарата, то я впервые о нем узнала после вот рассылки. И когда вот мы с Мариной связались о том, что, вероятно, вроде как бы проводились какие-то исследования, в частности, эпилепсии, по лечению эпилепсии, вероятно всего даже, может быть, в нашем центре, я не нашла подтверждения этой информации у наших коллег, которые, ну, достаточно долго там работают. Вот. Но по, скажем так, по составу, да, этого препарата, то, что там содержится фенобарбитал в небольших дозировках, в принципе, это, ну, не, скажем так, неэффективный препарат при лечении эпилепсии. И мы его точно не применяем. Вот. Что касается применения этого препарата у пациентов с алкогольной зависимостью, да, мы знаем то, что применяются препараты, антиконвульсанты, да, но больше даже как с таким наркотическим эффектом по типу фенлепсина. Вот, ну, препаратов прегабалина в том числе, да. Вот. Но что касается конкретно этого препарата, да, то, ну, у меня как бы возникают...
Ну да.
Мы о нем не слышали, мы о нем не знаем. И вот я говорю, впервые мы о нем услышали. Это очень странный препарат. Мне так показалось. И то есть
Тоже.
при всей меняется, но сейчас, как всегда, много действительно других более эффективных препаратов с хорошей научной доказанностью, там, да, с международными клиническими испытаниями на международном рынке, на российском рынке. Вот. Но, в общем,
А известно, что вот, ну, другие какие-то антиконвульсанты используются, ну, то есть какой их эффект, ну, какого-нибудь, любого, я не знаю, который вот вы часто используете, какой их эффект на как раз-таки стероиды, да, на кортизол, на ГАМК-А?
Мы, к сожалению, как раз не, ну, в частности, мы как бы не занимались конкретно этим вопросом, да, изучением гормонального фона, да, которые влияют. Но у меня пока нет таких сведений и данных, что конкретно антиконвульсанты, у которых, там, скажем, ну, точка мишени, да, то есть связаны в основном с рецепторами, да, то есть именно как-то влияли на гормональную, ну, то есть на гормональную, то есть на гормоны. Ну, то есть как-то там повышали их, понижали, ну, как бы, ну, как бы я не задавалась, в принципе, конкретно эти вопросы, мы изучали тоже этот момент, но если, да, посмотреть, может быть, что-то и выйдет. Но как бы нет таких сведений, по крайней мере, вот за мою практику, да, то есть как бы в эпилептологии, что вот конкретно какие-то препараты так вот, ну, как бы влияют, ну, по крайней мере.
Ну да. Ну, вообще тема, да, нейропсихоэндокринология — это достаточно такая новая, ну, относительно, да, новая отрасль.
Да, да.
Много...
Ну, новая, да, актуальная такая достаточно. В принципе, да, может быть.
Да, мне показалось, что сама вот статья, понятно, что к препарату действительно много вопросов, которые, к сожалению, остаются без ответов, но сам факт того, что вот это может быть мишенью для лечения, да, изменения гормонального, да, состава, вот это достаточно действительно интересная история, потому что мы понимаем, что в процессе алкогольной, да, и других видов абстинентного синдрома действительно мы видим вот эти вот, так сказать, напряжения стрессорной системы, да, которая проявляется в гиперкортизолемии, да, и сниженным уровнем ДГА, про который пока вообще мало что известно. Есть какие-то данные про его нейропротективный эффект, да, про положительное влияние на эмоциональное состояние, на когнитивное, но пока действительно достаточно мало.
Ну да, там просто у меня еще вот, да, возник вопрос, просто я бегала, конечно, смотрела.
Да.
Ну, как бы, есть еще, скажем так, физиологические ресурсы самого организма, да, и то есть, как бы, прошел какой-то промежуток времени, вот, то есть 3 недели.
Да.
И тут стоит вопрос, да, то есть, как бы, да, понятно, была вроде как бы контрольная группа, вот, но эта контрольная группа употребляла алкоголь, по сути дела, не было же влияния, да, алкоголь действительно влияет на гормональный фон, то есть он повышает, да, то есть, там, все гормоны, то есть дисбаланс их происходит. И просто со временем, может быть, произошла физиологическая компенсация.
Ремиссия,
да.
Тоже такой интересный момент.
Абсолютно, да. Мы как раз про это тоже проговорили, что сложно разграничить, да, где эффект времени, а где эффект препарата. Спасибо большое.
Спасибо.
Окей, move to the next slide. Okay.
Next slide is discussion. First question is why did you choose Galodif? Why this particular dosage? How clinically significant other effects of Galodif, and how safe is the drug, and what are its side effects? And second question.
No, let's talk about like first one and trying to answer this. Let's make the discussion. So I think like why did they choose Galodif? It's not really clear, and I think we already spent some time on this. Why they choose this dosage as well? It's no like clear data like why 300 milligram working, and I think this is also just make a small. Ой, а что случилось?
Вы пропали, сейчас появились.
Ой, извините. I think what we can discuss is one of the question which is not really covered in this paper. It's about safety, like how safe this drug, and they don't report any side effect, right? Any adverse effect, to be correct, this terminology. They don't talk us about this, and I think it's when we usually look on new drugs, we trying to understand what is the safety, and this is the first question which you should ask yourself when you trying to discover new drug, like is it safe or not? And next you move to the question of efficacy, and I think here it's one of the very like important limitations that they don't talk about safety. What about clinical significant effect? Like we see some change, but like we see statistical significant change, but what about clinical significant change? What do you think, Marina?
In the article is now said about clinical effects and so no reason exclusion participant in a study, and we don't know is side effects clinically too. It's
I think here it's kind of like tricky question, is it clinical effect, significant effect or not, because like what we're trying to find here, what is clinically important for us, for patients with alcohol addiction, is stable remission, right? And here they focus on steroid levels, and we really want to like how we would like to change these levels. We see that when we look on these tables, we see that levels of cortisol or ACTH, of DHA, they're in the normal range, right? Like
yes.
We don't talk about this, but like this is in normal range. It's not really like when we talk about like increased or like elevation of this level or decline of the level, but it's still in this range.
Yes,
it's normal. So we just see like this temporary pattern of change. And clinically significant, we don't really want to make like some changes in this level. For us it's important that person is stable and he is on stable remission, and I think based on levels of steroids we don't really can see clinical significant effect. We only looking on numbers and it's more important to have like statistically significant effect, probably, because we don't really know like in which level of cortisol it's like in normal range, which level is not desirable for clinical purpose. Is it understandable what I say?
Yes, yes.
Okay.
I agree.
I think it is strange that they didn't even ask their patients about withdrawal symptoms and didn't tell us about this.
Yep.
So to explain how cortisol correlates with withdrawal symptoms, because they also write in their article that disturbed homeostasis can be a risk factor for the alcoholism, but they do not make any correlations with it. So they it's strange for me.
Totally agree, and I think again, like when we're thinking about how this study design can be better, I just think that it's definitely on the baseline before treatment. You should be collect as much data as you can about the disorder which you study, and here it's alcohol withdrawal syndrome, and it's again, this is the question about like probably excuse me, the severity of withdrawal syndrome is also important. And for example, what is their sample size? Probably maybe some of these patients have very severe withdrawal syndrome. Some of them has just light and very like or mild severity, and we couldn't put everyone on the same plate and to look on the effect of the treatment, which we don't really know the effect of what can be effect. And it's really a great point, and I think this is like one of the missing spot here. Yeah. Does anyone have any other like maybe you see some other limitations which we don't cover yet? Because I think this is like paper have some of them, like some. I have a lot of questions to the design and why they choose this kind of study design, and like it's a lot of unclear information how this study was conducted. What else come to your mind? Like Marina point out here the question about randomization.
Yes.
Like when we have these two people, like with two groups of people, one a group of patients, the other group of control, it's actually hard to randomize. So it's just based on diagnosis, right? And when we talk about randomization, when we randomly put the participant in one group and the other participant go into other group. So here they go like they divided into groups just based on diagnosis, and so that's why particularly here randomization is not really make sense. But probably if we again like if we add the group of patients who wouldn't receive Galodif, and it's possibly that in this kind of design we can use randomization procedure, and also as well as we can blind them to make to control for placebo effect. Yeah. So Marina, what like if you have the opportunity of let's see you got a grant for several $1 million and you need to answer on the question, is the particular treatment, let's say Galodif, can be potential new treatment for alcohol use disorder by modulation function of HPA axis. What is in your mind? How you change this study design to make it perfect? or better at least?
I don't know. I think maybe I add to more participant in both group. I don't do randomized and blind these groups, and
Ekaterina, would you like to help? Or Natalia?
I agree with. I think that I would do like you, Marina said. The second group would be patients with alcohol dependence on such withdrawal as the first group, and they would be practically very схожи, как я забыла. So, and the first group would be treated with Galodif, and the second group would be treated with placebo. So, and they would be it would be an inpatient a trial. So for patients not to use alcohol for these 3 or 4 weeks, and also what else?
No, I think
also I would add some more data, of course.
More participants, you mean? Or more collected data, more questions?
Collect more data about participants, about their
Which one?
Clinical symptoms, withdrawal severity, so their probably their mental health level, and I would like to make blood samples sometimes, not one time on baseline and the second time on the end after treatment. I would do it during the treatment, so to see how levels reduces or increases.
Exactly, and here we have fourth question: why they do testing every day, but we see results only on first day and on 21 day? What do you think? Why they do this? So they actually collect a lot of data, right? So they collect it every day. And it actually makes sense to compare what you have on the first day and what you have at the end of this course treatment. It's not really treatment because we don't really know about therapeutical effect. I mean, in the course of this intervention, right? And it makes sense. But they collected this data. Why don't present it to us? And so probably we would see that during the time it's like kind of lower, like the concentration of cortisol is just lowering, and it's probably we would see this time effect. So probably that's why they don't want to share it with us. It's again like the point that when you talk, like when you present something on your methods, you also should talk about this in results, because you should present everything which you about what you collect. I mean, in the particular paper, when you talk like on one small questions and you should also put everything, any details about methodology, and if you don't present the data which you collect during this kind of methods, which you talk about in method section, so just don't just put it on your result section, and because otherwise it looks like you would like to hide something, and it's make us more nervous. I don't like it as a reader. I don't like it. Like, why you give me this piece of information if you don't use it? Why I should right? So it's also kind of so we discuss about this, not just saying that this paper is terrible. No, this paper is like is a paper, and it's teach us a lot of lessons. And I just want to point out some like limitations which every paper has, and no one perfect, and we would like to be, but not. And I think this is like one of the very common mistake that everyone talk about methods, but when you see in results, you see that they hide something from us. Okay, move to fifth one. Yeah, it's unclear, right? It's unclear, like which settings. Do this patient come and go to home and do whatever they want to do and then return? And they probably can drink alcohol but don't relapse. So it's also possible that like they probably, we don't really know. If you sip some beer, you actually take some alcohol, right? But you don't move to, you don't relapse because like it's not heavy drinking pattern like during several days. But do they control it? Or if it was inpatient, it's probably better and less questions from us, but still it should be on the paper, like inpatient or outpatient. Also the questions about adherence, like do they, how they control that patient, and also in control group. So we, like it's 100% guarantee that control group wasn't in outpatient clinical setting, they wasn't hospitalized, right? But how they can be sure that control group take their medication? It's actually hard to do this, like 3 times per day.
Yes.
Are they sure that they take it? 100% guarantee? And if they miss dose, so probably we don't see results. So probably this is explanation why we don't see results in control group. See? This is limitations. Okay.
It is unclear. It is unclear were this inpatient or outpatient study, but sometimes in articles they say that patients were abstinent. So they how can they know it?
Yeah.
But sometimes they write it.
So you can use actually markers. You can use markers in your blood, and you also can use breath analyzer, like it's like, and to see the concentration of alcohol in your breath. And also you can do so it's other very interesting questions about markers, and there are like huge amount of different markers which can catch, is it chronic alcohol use, or it's acute alcohol use, or it's alcohol intoxication. So it's possibility to do this. Usually, like in our study particularly, we use breathalyzer, and we use we talk about this, it's self-report data. When we ask actually patient, it's timeline follow back, special methodology when we ask person about their alcohol use in previous 30 days. And yes, it can be biased because people lie, everyone, and or they don't remember exactly the amount of alcohol they used. But it's also can be used, and it's better than nothing. So here we don't really know it like at all. No methodology at all on confirming alcohol use status during the time of observation. Am I answer on your question? Who asked me this question? Do you satisfy with it? I think you could say
yes.
Okay.
And I think I would like them to show on baseline alcohol usage of their patients.
Sorry? Can you repeat again, please?
Yes, you answer my question, and I also would like them to show alcohol usage of their patients on baseline. So
Yeah,
there is no also.
Exactly. Who is your patient with alcohol use disorder, right? Like, they talk about ICD-10 diagnosis, but it's also can be different kind of patients, because we know that alcohol use disorder can be different and different severity, and I think it can be like clinical anamnesis data is not presented as well as we would like to. Yeah, and it also can be a modifier factor. Okay. Do you have any other slides?
Limitations.
Them we discussed already. Let's talk about what we don't discuss yet. Selection bias, is it it's possibility that it's selection bias, right? Because we don't really know about the recruitment and enrollment process here, and like how they select their sample size.
Yes.
Okay. What else? So we talk about first one and third one.
Yes. And third.
Okay. Yeah, and a little bit about statistical analysis. Like usually in the paper you see the whole paragraph about statistical methods, and here unfortunately we just can assume something, but it's not clear. And one of the problem for statistics here is disproportional number of participants in two groups. So as you see, it's about like two times more in treatment in patient group compared to control group, and it's kind of problematic for statistical analysis, especially if we talk about so small sample size. And usually we actually would like to see more than 30 participants in the group to make our statistical analysis proper. And I think this is the one of the area for which vulnerable for biases. But we don't really know what they use, and we just again say that it's unclear, we don't really know. Probably it was proper and good, but we for now we just learning about it. Okay. I think that's it, right?
Yes.
Okay. Marina, would you like to make a resume of like what you take home points from this paper, from our discussion? Like, what is your resume?
Now?
Yep.
I think what this article and this study is not not good.
Если хочешь, можно на русском, если так будет проще.
Да.
Без проблем.
Хорошо. Мне кажется, что данная статья, она нельзя как бы относиться к ней достоверно, но потому что тут нарушены, как бы не особо доказательно, вот начиная с количества участников, и особенно это критерии включения, не включения, то, что не описаны методологии, то, что непонятно, по каким причинам выбран препарат, то, что все вот клиника не описана, и не описаны дозы, почему именно такие выбраны, и сами группы участников тоже не описаны. В общем, в целом складывается впечатление, что как бы тут есть конфликт интересов, вот, так как и препарат этот тоже даже по своему назначению, как антиконвульсант, он не дошел до конца исследований, даже на людях. Но его еще пытаются в то же время ставить как исследование на людях уже по другим показаниям, и это весьма, странно. Вот, так, так что вот.
Все ли согласны с таким достаточно суровым вердиктом Марины? Или есть возражения? Может быть, кто-то отметит, какие есть сильные стороны в этой статьи? И не обязательно, можно, наоборот, добить их. Добавить какие-то ограничения, которые мы упустили. Если чувствуете, что лучше на русском, можно на русском, да, мы не только тренируем английский, да, но и, в принципе, да, критическое мышление — это тоже наш цель.
Я еще могу сказать из положительного то, что тут как-никак все-таки, допустим, указан возраст и средние показатели, и вот боксплоты, они описаны, то есть хоть и странно, как бы сложно было иногда понять, и там были какие-то недочеты, но они все-таки есть, и в таблицах все довольно, было описано и указано. Вот.
Да, согласна. Немножко непонятно вот с таблицами ее логика, да, про вот эти вот звездочки, что с чем сравнивалось, да, не очень понятно, нужно посидеть, подумать, но потом вроде все становится понятным. Согласна. Да, и действительно, то, что спасибо за графическое изображение, потому что, как правило, бывает раньше, что вообще только там средние указывали, и непонятно, насколько там вот этот вот идет разброс данных, и тоже это здорово.
Да, можно я тоже?
Да, конечно.
Да. У меня возник вопрос, как эта статья вообще вышла в печать. То есть ее кто-то рецензировал, причем это же статья, она же не просто в российском журнале.
Да.
Она достаточно, в таком, все-таки любая, на мой взгляд, любая зарубежная статья в англоязычном журнале, она должна проходить достаточно...
Сейчас хочется попросить Марину перекрутить на слайд, где написан выходные данные статьи. Импакт-фактор, например.
Да, я полностью согласна с Мариной, вот, что действительно очень странно, что дошло, ну, скажем так, до нас, до эпилептологов не дошел этот препарат.
Мгм.
Это, по сути, это какой-то off-label.
Ну да.
Ну, по сути, да.
Да, то есть как бы получается, что нет достаточно хороших клинических проведенных исследований.
Ну, я согласна. И более того, говорится, там есть такое предложение про этику, да, и то, что этический комитет одобрил же, да, это исследование.
Мгм.
И я понимаю, ну, как бы про здоровых волонтеров, тут, ну, действительно, ну, они дали свое согласие, а тут все-таки пациенты, как вот они, ну, вот как этический комитет, вот вопрос, наверное, больше к нему. Вот, потому что ученые — это ученые, они могут изучать что угодно, и, ну, это действительно интересный вопрос. Вот, тут больше к этике.
Да, такой к организации. Вот, ну и еще я по поводу вот группы, да, что мужчины, не знаю, нам, опять же, может быть, они проводили какие-то более масштабные исследования и просто выбрали как одну из показательных групп, выбрали, то есть, мужчин, вот, и просто выставили более, скажем так, показательные данные, которые
Ага.
появились, и, то есть, соответственно, они на основании их выпустили эту статью, как вариант, не знаю.
Так, я правильно поняла, что они выбрали мужчин, чтобы увидеть, чтобы более показательную выборку для того, чтобы увидеть эффект?
Просто очень странно, почему они вообще действительно выбрали такой дизайн, да?
Да.
Вот, и почему конкретно просто только одни, ну, там действительно мужчины участвовали в этой статье.
Да.
Может быть, да, у них было более, скажем так, обширное исследование, и они из этого исследования взяли наиболее показательные данные, которые получились, ну, соответственно, которые показывают то, что препарат эффективен, да, вот, и, ну, как бы взяли эти данные для статьи, как вариант.
То есть я правильно понимаю, что вы хотите сказать, что в более обширном исследовании участвовали как и мужчины, так и женщины, и была большая выборка, и они просто отобрали данные, как более маленькую выборку для статьи?
Ну, тут таких данных...
Просто мы не знаем, действительно, ну, то есть тут, конечно, много вопросов к исследователям, да, почему они выбрали именно эту группу, почему именно такой дизайн.
Очень плохо слышно.
Вот.
Ага, вот сейчас
Нормально?
просто...
Вот так получше
Вот
слышно?
отлично, так просто супер.
Просто, ну, почему возникает вопрос, да, почему они выбрали конкретно этот дизайн, почему они выбрали конкретно эту группу, и, ну, как вариант может быть, да, то есть, что у них действительно было более широкое исследование, из которого они выбрали более показательные параметры и выпустили как статью, как вариант.
Да, тут мы можем только гадать об этом. Ну, я думаю, если у них было большое исследование, они бы обязательно на него сослались. Увы, ссылок на предыдущие
Ссылок нет,
данные
да,
нет.
никаких?
На предыдущие данные, насколько я помню, Марина, поправь меня, если я не права, нет, их нет.
Нет, нет.
Они печатали такую статью на русском языке, вот, но это то же
В
самое.
2013.
Да, это тоже те же самые как бы данные.
Да.
Вот, поэтому, ну, мы можем только гадать. Мне кажется, возраст, пол, да, то есть они выбрали только мужчин, просто потому что, ну, как обычно, да, мы хотим, если какой-то эффект физиологический увидеть, то все-таки гендер, да, пол — это дополнительный физиологический, да, фактор, который может оказывать влияние на физиологические процессы, да, и просто чтобы убрать этот фактор, влияние этого фактора, да, биологического пола, они ограничили свою выборку только мужским полом, чтобы, грубо говоря, ее не... Ну, убрать вот этот шум, который может быть из-за плюс одного пола, да? Вот. Просто слишком может быть влиятельность сильная, да, и которая диктуется именно полом. А тут этот фактор убрали, более чистые данные, чтобы получить. как бы действительно для более большого исследования, конечно, да, вот и опять, когда я спрашивала, да, вот если было бы у нас много миллионов, чтобы сделать это исследование, как бы мы его сделали, конечно, я бы, ну, вот, например, да, еще добавила бы группу не только мужчин, но и женщин, и посмотрела бы, а есть ли какой-то еще гендерный эффект, да, на вот это, на эффект препарата на стероиды. Ну, наверняка он будет. Вот. И, конечно, было бы любопытно посмотреть, в какую сторону он будет. Вот. Так что это вопрос открытый. И, ну, мне кажется, наоборот, правильно, что они это сделали. У них очень мало людей, и как раз чем чище выборка, тем лучше. Чем более гомогенная выборка, да, тем лучше. Хорошо. Кто-то еще хочет высказаться? Какие-то еще есть мысли, предложения, комментарии, вопросы?
Ну, я могу вот сказать,
Угу.
ну вот, если на русском начали говорить, что, ну вот, какой я вижу результат в этой статье, это, ну, очередное доказательство тому, что при применении, при хроническом употреблении алкоголя происходит, как бы, разбалансировка вот этой вот гипоталамо-гипофизарной надпочечниковой системы, и вот как здесь видно, что в выборке пациентов с хронической, ну вот, с хроническим употреблением алкоголя были более повышенные уровни кортизола, там был снижен ДГА первоначально, и, ну, и в очередной раз подтверждает эти данные, что в период, как бы, абстиненции, а потом и ремиссии, что происходит какая-то некая нормализация. Никакого эффекта препарата, вот, ну, лично я здесь не вижу, потому что, ну, странно, в общем-то, это сравнивать, две группы между собой, когда такой, как бы, фактор, как влияние синдрома отмены, он, как бы, есть только в одной группе. И это странно. Ну, то есть его же надо как-то убрать, а они его не убирают. И как-то еще пытаются смотреть на эффект препарата. Мне кажется, это, ну, просто невозможно здесь увидеть.
Согласна. Очень много факторов, которые влияют, и действительно понять, что из этой мешанины привело к тому, что мы получили, возможно, тем более на такой выборке. Спасибо. Так, Иван, Павел, что-то есть добавить, спросить?
Я хотел поблагодарить за возможность поучаствовать в таком мероприятии. Мне, конечно, как не медику, сложновато было воспринимать часть информации, но меня очень впечатлила глубина критического анализа. Очень здорово, что вы таким занимаетесь. Спасибо.
Спасибо большое, очень приятно слышать. Так, Павел, у нас сегодня такая маленькая группа достаточно, так что по всем пройдемте.
Да, но я тоже хочу поблагодарить за представление статьи. В принципе, ну, все было понятно. У меня нет каких-то вопросов еще оставшихся. Вот.
Спасибо.
Ну, кстати, коррелируя с проектом гранта, который я недавно читал, тоже те же гормоны и похожая ситуация клиническая.
Да. Дело в том, что у нас действительно проходит и сейчас вторая часть проекта, которая очень схожа, вот, ну, в чем-то, да, схожа с дизайном, который здесь описывается, так что, да, поэтому, собственно, эта статья попала мне под руку, и я решила ее посмотреть, потому что с таким я еще не сталкивалась, да, с интервенционным исследованием, которое пытается повлиять на нейроактивные стероиды. Так что любопытно. Хорошо, я вас всех очень благодарю. У нас, я думаю, сегодня прям получился очень интерактивный, динамичный журнальный клуб. Мы в итоге, конечно, скатились на русский, но я думаю, на английском тоже попрактиковались. В общем, увидимся, я надеюсь, 26 мая. У нас там статья тоже достаточно интересная. И вот, тогда буду держать в курсе дальнейших новостей. В июне мы тоже кое-что интересное планируем, потом вам расскажу. У нас будет скорее не журнальный клуб, такой будет семинар на про клинические исследования от человека, который работает в индустрии. Мне кажется, это тоже такой полезный будет взгляд, потому что академия — это одна сторона медали, индустрия немножко другая, поэтому было бы, я думаю, это полезно всем. И тогда, если есть какие-то вопросы, пожалуйста, напишите и уделите время. Я вот не просто так прошу вот Марину, она вышлет вам опросник по тому, по вот вашей обратной связи, да, что понравилось, что не понравилось, чтобы вы добавили. И иногда приходят действительно очень классные идеи, и вот, например, кто-то написал, что нужно резюме на русском, и мы это добавили, то есть мы пытаемся действительно активно делать то, что говорите вы. Вот.
Откликаться, да.
Да. Так что я понимаю, что мы уже все друг друга хорошо там знаем, ну, практически, и уже добавить нечего, но каждый раз все равно какие-то, да, там мысли, может быть, проскочат интересно, и будет здорово, если вы это все, в общем, с нами поделитесь. Спасибо большое за ваше время. Я записываю, так что ссылку потом записью тоже вам пришлю, где вы можете посмотреть или кому-то ее отправить, если вам показалось, что, может быть, кому-то это вдруг будет тоже интересно послушать. Будет тоже здорово. Вот, тогда у меня на сегодня...
Всем спасибо.
Спасибо
большое.
Спасибо.
Спасибо.
Тогда всем до свидания.
До свидания.
До свидания.